And for the last session for today on the topic of multidisciplinary approach to treat obesity management, it is my honor to introduce you our moderators for this session. Our first moderator needs no introduction, Professor Francis Chan. He is a world-renowned clinician, scientist in gastroenterology with over 860 publications. Currently, he is the Chomingli Professor of Medicine and Therapeutics and the Director of the Center for Gut Microbiota Research at the Chinese University of Hong Kong. And our second moderator also needs no introduction. Professor Yoshio Yamaoka is the Vice President of Oita University, Japan, and is the Chair and Professor of the Department of Environmental and Preventive Medicine at Oita University.
Okay, thank you very much. So this is the last section of today. So we have the two talks. So the first talk is Associate Professor Sanit Wichansawakun is okay. Okay, so it's from the physician and the lecturer in the Department of Internal Medicine, Faculty of Medicine in the Pattharasai University. So Sanit, please start.
Good afternoon, everyone. Thank you, the organization, for inviting me. It's such an honor to be a speaker today. So my lecture is about update on pharmacotherapy for obesity. So this is my disclosure. My talk today, I will overview about obesity and importance of pharmacotherapy. So we will know nowadays what we have for current medication and what the future trend. And I will summarize the strategy to implement anti-obesity medication to our patients. As everyone knows, we are facing with obesity pandemic. Nowadays, 764 patients live with obesity. And in Thailand, it is a huge issue too. There are an increasing the number of obesity prevalent in Thailand and in Southeast Asia country. Obesity is associated with multiple complications, either metabolic complication, mechanical complication, and also mental complication. And we have to deal with these all complications. And also, obesity is one of the leading risk factors for early death. You can see the death rate from obesity, and in Thailand, it is also increasing in the number of dead people from obesity. So as a physician, we treat the patient with these all complications. For example, for gastroenterologists, you deal with gallstone, navel. But when we see all of these complications, we have to think about obesity because we need to stop obesity problem so we can stop all of complications or can improve the patient quality of life. You can see that the number of weight loss not quite high. You don't need to decrease body weight of the patient to be normal BMI. If you just let the patient decrease only 5% of weight loss, you can see that some patients have improved in their blood pressure and also blood glucose. And over 15% weight loss can lead patients with diabetes to be the diabetes remission and can decrease cardiovascular mortality. So we need to identify which patient that we call obesity. So obesity is defined as an excess fat accumulation. Nowadays we use BMI just as a screening tool. Why we say a screening tool? Because when we have two people with the same BMI, same body weight and same height, one patient who have higher muscle mass, it might not have a problem. So we need to identify excess fat. So we recommend every people to do annual checkup of their BMI. And if they are higher BMI above normal range, we suggest to do bedside waist circumference in order to identify abdominal fat obesity. Because increased waist circumference related with all comorbidity. What about us as a physician? Were you concerned about the body weight of your patients? I would like to show this study that's quite impressive. This is the study from Saudi Arabia called the Action IO. They did the study to ask about perception attitude about obesity management. They did the study in healthcare professional about 200 physicians and see that most of them are specialists and 36% is internists. The green bar is the data from healthcare professional. More than half of healthcare professionals, sometimes they doesn't ask about patient body weight because they think patient is not interested in losing weight or the appointment is not long enough for talking about patient body weight, and almost half of them think there are more important health issues apart from obesity. And sometimes they think it's not insignificant problem. Actually, obesity is recognized as a chronic disease, and we have to treat obesity. So for stepwise approach to manage obesity, we have to encourage all people who live with overweight to eat healthy, to implement lifestyle management with well-balanced diet and regular physical activity. However, you can see that we have to decrease body weight over 5% to see the benefit. But for lifelong, many patients who have lifestyle management can lose less than 5%. This is some limitation from lifestyle intervention because the number of weight loss is not high as we expect. And also for sustained of weight loss, most of patients regain after 4 to 7 years. And for morbid obesity, like the patient who have higher BMI at above 30 or 40, it is hard to lose their body weight to that such a high number of body weight. And for bariatric surgery, even though the bariatric surgery is the most effective treatment, but it restricts to only class 2 or class 3 obesity, and there are some people that might not fit for bariatric or not acceptable for bariatric surgery. This is the gap that we need to use pharmacotherapy to be an adjunctive therapy. I say that it is only adjunctive therapy. It means you need to implement lifestyle modification, and if patient indicated to use pharmacotherapy like BMI over 27 with adiposity related complication or BMI over 30 without any complication, and they fail to lose their body weight above 5%, you can think about medication to be an adjunctive therapy. Before talking about medication, I would like to show this is the normal physiology. When we eat food, we have the homeostatic system that control our eating balance. So the gut did have the neurotransmitter and also gut hormone to inhibit eating at the higher brain, at the brainstem function and hypothalamus. However, as a human, we also have higher brain function that we call hedonic system. You can see that only we see food, we smell the food, and we just taste the food. The food didn't come out to your gut, but that higher brain function work to stimulate appetite. So this is why we cannot use only medication to control our gut-brain axis to win with obesity, but we have to implement good environment and also manage with cognitive function and reward system. So for homeostatic eating, we can use some medication to help. For hedonic eating, sometimes some medication work, but for executive function that can control eating, you have to use behavioral intervention, and this can be the lifelong that we can successful weight loss. Because we have many receptors in our brain and our gut and also in adipose tissue, this is the sign that medication will work. And this is the medication that available nowadays. And I think everyone, someone familiar with orlistat, right? This is only peripheral blockade of fat blocker. But we also have old medication like pentamine that block our central system to inhibit appetite. But nowadays we also have new medication or novel medication that can block central and peripheral feedback mechanism, that is GLP-1 analog and GIP-GLP-1. Look at the number of weight loss for medication. In the past, we can lose about 5 to 10%. But for novel medication, some medication like tirzepatide can make people to lose more than 20%, which is quite impressive. However, we still need to follow up and to see the adverse event. Actually, in the past, we have many medication, but all of them have cardiotoxicity, liver toxicity, and the last one, lorcaserin, that just withdraw from the market because it's increased risk of cancer. Also, for old medication that we still use nowadays is pentamine. Actually, it's not allowed to use long term because of drug abuse and also may increase risk of cardiovascular disease. For pentamine, we use only short term because it have a tachyphylaxis and increased CV risk. And for combination drug that control central system to inhibit appetite also create only 5 to 10% weight loss. Orlistat is not a good medication because the number of weight loss for long term is not quite high. We have new medication that can create about 15 to 20% to help people to lose weight, and other benefit that many studies show the benefit for cardiovascular outcome because the receptor of GLP-1 analog and GIP is not only brain and gut, but we also have receptor in many organs like heart, brain, and also liver. And for the mechanism of GLP-1 analog, glucagon and GIP that can work together to improve weight control and also create other metabolic outcome. For example, in liver, it can help decrease hepatic steatosis. And this is the study to show that GLP-1 might benefit MAFL because it can help decrease fat accumulation in the liver cell. And nowadays it is evidence-based medicine that our novel medication like GLP-1 or incretin peptide-based medicine can improve obesity and also can treat diabetes type 2 and prevent cardiorenal disease. And there is some new data to improve like diabetic kidney disease and still investigate about metabolic complications like liver disease and also Parkinson and peripheral artery disease. So for ESC 2019, in diabetic patients who attribute cardiovascular disease, they suggest liraglutide and semaglutide, which is anti-obesity medication, to use as a class 1 medication. Because many CVO trials with GLP-1 can show the benefit of decreased 3-point MACE. Anyway, we need to know about complication and also contraindication for all medication. For orlistat, I think everyone know that we need to be careful in chronic malabsorption patient. And for pentamine, topiramate, and naltrexone, bupropion, we need to be careful about drug abuse and psychological issue of the patient and also increased cardiovascular risk factor. For novel medication like GLP-1 and GIP, the contraindication that you have to ask is the personal or family history of medullary thyroid cancer and men too, because this is contraindication for the medication, and also the patient who have the history of acute pancreatitis So we have many medication, but how can we enhance the efficacy of medication? Because obesity is the complex disease. It had many factors that contribute to imbalance of energy expenditure. So there is a study that tried to distinguish patients based on dietary intake, eating habit, and also in using energy expenditure. They categorize the patient into 4 types of the patient. First, hungry brain is like the patient who cannot feel full. They eat the big meal, and the second type is hungry gut. It means like picky eating. They need to snack many times because when the gut empty, they feel hungry many times. And third one is emotional hunger. It means they want to eat when they feel depressed or then they feel happy. And finally is the slow burn, which have low energy expenditure. If we want to target this phenotype with medication, for hungry brain, we might use pentamine topiramate. For hungry gut, we might use GLP-1. For emotional hunger, we might use naltrexone, bupropion. And for slow burn, it is hard because no medication that can have significant increased energy expenditure. So we might use pentamine in short term in order to help patients to inhibit appetite and feel alert and implement physical activity. Based on this study, if we target medication based on majority of phenotype, we can have the highest number of weight loss and the higher number of the patient who can lose more than the patient with not target with phenotype. So to summarize how to use the medication, I think we have to identify the patient with the criteria that we can use medication, implement lifestyle modification in every patient, then think about age and comorbidity. If patient with younger than 65 and no comorbidity, actually all medication can use. However, in older patient, we have to be careful about cardiovascular disease and the risk factors. So GLP-1 might be the safe one that used for this patient. And for patients who have comorbidity, we have to ask about contraindication of GLP-1 first, and then think about metabolic complication. We can use like GLP-1. And other disease like OSA, depression, we can use some medication that can help. We have many medication that will come out in the future that will block with that will work with GLP-1 receptor and glucagon and GIP receptor. You can see many medication in the pipeline for the future, and the number is quite better than the past. For example, you can see that some medication like retatrutide can lose more than 25%. So the number is almost the same with bariatric surgery. However, you have to deal with weight regain after 1 to 2 years of weight loss. It tends to regain weight because decreased energy expenditure, but they feel more hungry and want to eat more. And many studies for medication show that patients also lose their muscle mass. And this is the key because other type of intervention like dietary intervention and also bariatric surgery, about 25 to 30% of patients also lose their muscle mass, and muscle mass might be the key that can help us to successful of weight loss long term, because medication can help us reduce adiposity, reduce complication, but still lack of the efficacy to preserve muscle mass. So keep in mind, you still need to educate patients with nutritional intervention and also physical activity in order to help patients to succeed in long-term weight loss. So as obesity as a chronic disease, it's like we run marathon. So we need to implement every strategy like lifestyle intervention and think about medication in some patients. So finally, I think it is the significant problem nowadays with obesity. So we need to lose at least 5 to 10% of their body weight to help them to improve obesity outcome. And if we know what to use with the patient and we prescribe medication under safety and efficacy consideration, you will successful of management obesity patients. Thank you.
Okay, thank you very much. So this is a very systematic review and it's very easy to understand. So it's a very good presentation. Now this presentation is open to discuss. So do you have comment or? Okay. Okay, so please.
Professor Traffis, you didn't, a very nice talk, but you didn't say anything about side effects and adverse effects of the GLP-1 receptor agonist, because the balance of risk and benefit varies according to the size of the patient, clearly. There's a lot of pressure for trying to treat moderate obesity, as some of your images showed, but what are the risks as far as gut motility or dysmotility, gastroparesis, and that sort of thing is concerned?
Yes, GLP-1 also have a lot of side effects in terms of GI side effect. For example, like when we want to start the medication, we need to tell the patient to adapt their food intake, like avoid fat food and also a small meal, and have to increase the medication slowly in order to
I was thinking more about the proportion of people who really did suffer with an ileus or gastroparesis and vomiting and things like that. I think it's uncommon, but I just don't know the figures.
For the percentage of the patients?
Yeah. What proportion of patients have side effects?
Actually, for the GLP-1 based on like liraglutide and semaglutide that did the study in diabetic patient, I think it less than 10% of the patient have side effect, and actually it comparable with placebo. And also like in diabetic patient for hypoglycemia, it's comparable with placebo. So I think it about like the way you increase medication, and we have to educate patient before starting medication.
A fascinating talk. So mostly right now, so AGA, and now Francis, we know very well about the treatment obesity. So I believe that the gastroenterologists have to know the obesity very well. So we use a lot of GLP-1. Available in here is semaglutide. The problem is that the very first, the patient's gonna face with the acid reflux or GERD symptoms that should overcome with the PPI. But anyhow, after we treat the patients for just like 4 to 6 months, the body weight is coming down. And when we stop the medications, the body weight rebounds again. You have any techniques that we can use just like to minimize or step down the treatment to maintain the long-term control of the body weights?
Yeah, actually, I think you have to implement diet and exercise, because like
that's the most difficult part,
yeah,
right?
sometimes when we prescribe only medication and we will not like we don't educate them. Sometimes they eat like empty nutrients, less calorie, and this will affect decrease energy expenditure in long term, and this can be an yo-yo effect after you stop medication. So in my idea, you still need to implement healthy diet, high protein intake. But sometimes based on the study, we can use long term, like more than 6 months. Basically, we can use this medication for 2 years. And after we stop medication, and if they gain back, sometimes we can go back to start medication again.
Any role of a step down the medication, just reduce the dose?
In my experience, I step down. For example, if you use liraglutide at 3 milligrams, we try to step down to 2.4 and 1.8 and then 1.2 and can stop medication.
And using a GLP-1 receptor agonist followed by FMT, in other words, change the microbiome. I think that, Francis, thank you. I'll have some of your microbiome, please.
Yeah. I think this is the great question, but to be honest, I think we will not have the study directly about GLP-1 and gut microbiota, but I believe it because of the diet that patient eat. Because if you see the study, if patient try to lose weight with Mediterranean diet, it can give the variety of gut microbiota. On the other hand, if you lose weight with like ketogenic diet, the gut microbiota will getting worse. So for long term, I think we still need to encourage patients to eat good diet to improve their gut microbiota.
Okay. May I ask about the for obesity phenotypes according to Mayo Clinic? I just would like to know that about how to Mayo Clinic differentiate or categorize 4 types of the patient by just on the questionnaire or the blood test and how can we use to in our clinic or practical
For the phenotype.
In our practice, how can we use it?
Yes, actually, they did only questionnaire to ask about eating habit and regular physical activity, frequent time of exercise, and do only indirect calorimetry to measure resting energy expenditure. They didn't do any blood test. So I think it's pretty easy to ask the patient like the eating pattern during the day and what they eat, big meal or snacking during the day, something like that. Yeah.
Dr. Sanit, this is a very interesting topic. I guess if only we have 3 days, we can continue the discussion. But I just can't help ask the final question. In your guidelines, you use BMI of 30 as a cutoff. But we know that the WHO classification for overweight and obesity in Asia is different. Yeah. They use a cutoff of 25. But
yeah, actually for bariatric surgery, we have the lower cut point of BMI minus 2.5 for Asian people. Unfortunately, for medication that Thai FDA approved, and I believe that they still use the same number with Western country. But if you say like we can use as an off-label for lower BMI, but I think we have to choose the right patient to start medication. But in my practice, I start lower than 27 in some patients.
Thank you very much. Yeah. Maybe we have many questions, but anyways, now the time goes. Thank you very much.
So our second and the last speaker of this session is Dr. Kachornvitaya. Dr. Kachornvitaya is a clinical fellow in minimally invasive surgery at King Chulalongkorn Memorial Hospital. He is specialized in advanced minimally invasive and bariatric surgery and has done his fellowship and with a lot of experience in this field. Today, he is going to talk about how to choose what weight loss surgery is best for your patient. This is a very interesting topic. So the floor is yours.
Thank you for a kind introduction. I am Dr. Pattharasai from King Chulalongkorn Memorial Hospital. Now, I'm also work in the MAS and bariatric surgery unit. So I think I'm the only surgeon here, so please be kind to me. Oh, he is there. Okay, I have nothing to disclosure. So my outlines will be introduction, and we will talk about the long journey of the metabolic and bariatric surgery, and also the patient consideration and evaluation, and also the expected outcomes and benefit. So as Dr. Sanit said, the obesity is a chronic disease that impact on our health risk, mental well-being, and also the economy and social dynamics. Nowadays, by 2022, more than 1 billion people around the world were living with obesity. But for the metabolic and bariatric surgery is an effective, safe, and durable therapeutic option for most patients with obesity in the long term. So yes, obesity management is like running a marathon, as I am also the runner. So because we have to preparation and planning, and we have a long-term commitment with our patient and ourselves to treat our patient, and also overcoming the obstacle, like your friend bring you to eat shabu buffet That's the obstacle. And also the pacing, not every patient have to do the same. And also the important thing is support system. And your mental strength, I think this is one of the most important. And also achieving your goal. But it's an unending journey. We have to lifelong take care of our patient. So for the approach to obesity management, I think we have already talked about lifestyle modification, medication, endoscopic intervention, and also metabolic and bariatric surgery. So I think medication and endoscopic intervention is our complementary and the adjunct. We have to complement to each other to benefit of care of the patient. Sorry. So for an indication for metabolic and bariatric surgery nowadays, for ASMBS and IPSO guidelines in 2022, they recommend BMI over 35 and a BMI of 30 to 34.9 with metabolic disease. And also for the ASEAN, they encourage to lower the BMI to 27.5 should be offered MBS. This revised guideline just passed 2 years ago. They lowering the criteria about 5 points of BMI. But for our Thai society and for metabolic and bariatric surgery guidelines that published in 2019, we use the same. For the Asian people of a BMI 37.5 and BMI 32.5 with a comorbidity. And also for the patient who have a BMI lower than 32.5 with metabolic syndrome, especially type 2DM, we encourage to do the MBS or bariatric surgery according to the multidisciplinary team. So to the question of why choosing the best weight loss surgery matters, I would say that no best weight loss surgery. But I will change to the why choosing the right weight loss surgery matters. Because it impacts the patients in health outcomes, quality of life, post-operative lifestyle, and also the long-term success. So I will bring you to the history and trend of the MBS nowadays. 1950s, we have a jejunal ileal bypass, and in 1960 to 1994, we have a lung wide gastric bypass, both open and laparoscopic. And in 1979 and 1993, we also have a below pancreatic diversion and duodenal switch. And in the early 2000s, we have a sleeve gastrectomy as the first stage procedure of the BPDDS, but we found that it had a promising outcome, so we give it as a standalone procedure after that. And 2007, we have a study of single anastomosis duodenal ileal bypass with sleeve gastrectomy. And for in Asia, we also have a sleeve gastrectomy plus procedure that established in 2009. But nowadays, we don't have jejunal ileal bypass anymore, so because we have a high morbidity and mortality. For the current procedures in Thailand, I would say that we also have the dominant 4 procedures as a lung wide gastric bypass and sleeve gastrectomy, studies, and sleeve plus procedure. So for the trend of MBS in North America, that you say the sleeve gastrectomy is highest in the number since about 2007 and until now, about 70% of all procedures. Followed by the lung wide gastric bypass and revisional surgery, and also the rest is BPDDS, studies, and ESG. For in Asia, you see that in 2010, we also have adjustable gastric banding, but due to the high complication of the gastric band itself, after that, it's less popular. So after 2007, the sleeve gastrectomy is increasing to the majority, about 70%, followed by lung wide gastric bypass and also SEDI procedure. But after about 2020, we also that we have a sleeve plus procedure and also SEDI that are increasing the popularity in Asia. So I will touch a little bit about the mechanism and effect of the MBS. So I would say that we have a gastric restriction, we have a malabsorption effect, and also the combined both effect together. And how MBS affect weight and metabolic outcome. Yeah, the important thing is hormonal change in the gut-brain axis. We have an increase in GLP-1, PYY, CCK, insulin, and oxytocin. and the decrease in the level of ghrelin, leptin, and GIP. And also the increase of bile acids and the alter of gut microbiota. These are the factors that play the important role of the effect of the weight loss and also the metabolic outcome of bariatric surgery. Okay. For the type of MBS procedure, I will speak quickly. So the first procedure is sleep gastrectomy. That you will see that the volume of sleep is about 75 to 150 milliliters, and we use 32 to 40 French of bougie size to approximate the sleep volume, and 1 to 2 centimeter transection from the esophagogastric junction, and 2 to 6 centimeter enterectomy from the pylorus. For the pros of the sleep gastrectomy procedure, I will summarize that it's a less complex procedure. They have an outcome about 50% to 20% of excess weight loss and less nutritional deficiency, and also the less procedure-related complication. But for the cons, it's irreversible and it has a potential long-term reflux. And also the recurrent weight gain up to 20 to 25% for sleep gastrectomy. And it's less effective for the higher BMI and also the severe metabolic disease. So I would say that it is suitable for the patient with a lower BMI, usually about 32.5 to 45, and also the high-risk patient who have a severe metabolic syndrome, or a patient who have a waiting list for transplantation, and the patient who can accept more nutritional deficiency, and who less strict to adherence to follow-up and supplementation. For the reiterative contraindication, we say that we have about patients who have a severe GERD or have a Barrett esophagus and also the hiatal hernia. For the long-wide gastric bypass, we decrease the volume pouch to about less than 30 milliliters. And for the low limb, we have variation length from 50 to 150 centimeter for the low limb. Here is the low limb. And also for the below-pancreatic limb, is from remnant stomach to the below-pancreatic portion, about 50 and to 150 centimeter or so. And this is a conventional way the food and the secretion from liver, gallbladder, pancreatic mixed together. So for pros, I think long-wide gastric bypass have a higher in excess weight loss, about 60 to 80%, and also have a sustained weight loss than sleep gastrectomy, and a high success rate in severe metabolic disease like a type 2 diabetes. But for the cons, yeah, they have a more nutritional deficiency, especially for B12. You have to stick to the nutritional supplement, especially for B12. Yep. And more specific complications like a dumping syndrome and also the internal hernia, marginal ulcer is also concerned. And it requires strict lifelong adherence to the supplementation. Who is suitable for long-wide gastric bypass? I would say that patient with a higher BMI, usually more than 45 to 50, and who have a severe obesity-related conditions like a poorly controlled diabetes, and also it remains as a conversion procedure in the patient with severe GERD after sleep gastrectomy or the patient who have the weight regain after sleep gastrectomy. For the relative contraindication like chronic disease or disease require medication that absorption is affected by the bypass surgery. For the single anastomosis duodenal ileal bypass, for the sleep tube, it's like a sleep gastrectomy, and the length of a duodenal ileal limb is about 250 to 300 centimeters from the IC valve. And this is a portion that we bypass. Sorry. For pros, it has increased the weight loss more than 20 to 90% excess weight loss due to the higher bypass portion of the bowel. But for the cons, the more nutritional deficiency is the best concern for the SADIS operation, and also concern long-term for GERD, protein caloric malnutrition, and the gas bloating, and also the biliary access. And it also requires a lifelong adherence to the supplementation of nutrition. It is suitable for the patient with a higher BMI, usually I think about 50 to 60, and also a patient who have severe obesity-related complications, and as a conversion procedure also. The cause is like a gastric bypass who have inflammatory bowel disease, short bowel, and present of a severe GERD or Barrett's, esophagus and hiatal hernia. And the last is a sleep gastrectomy plus that in over Asia we developed in Taiwan and Japan by Dr. C.K. Huang and Dr. Kasama. The rationale for the sleep gastrectomy plus is less dumping syndrome and reactive hypoglycemia, less occurrence of anastomotic stenosis and marginal ulcer, and also easy to access to the remnant of stomach by standard endoscopy for the incidence of the gastric cancer. For the sleep proximal jejunal bypass, or we call PJB, is a sleep tube like a sleep gastrectomy, and the bypass proximal jejunum about 250 to 300 centimeter. And for the sleep duodenal jejunal bypass, we call DJB. The sleep tube is also the same as sleep gastrectomy and add on for the bypass component like long wide gastric bypass. Its efficacy has about 60 to 90% of excess weight loss and also the high success rate for severe metabolic disorder. For the cons is a more nutritional deficiency and concern long-term gut biliary access and also require strict lifelong adherence to supplementation. This operation is quite, I would say, not so new, but we have to collect the data for the long-term efficacy and also complication. But for the patient with higher BMI, around 45 to more than 50, this is quite a good option. And also for the who have a severe comorbidities, patient with high risk of gastric cancer, and also as a conversion procedure after sleep gastrectomy. And the relative contraindication is also like a sleep gastrectomy. So I think this part would be the best answer for the best option for the patient. It's a patient consideration and evaluation. Which way should I go? We have a lot of operation and also the treatment option for the weight loss and also the diabetes. So the patient journey will be a preoperative evaluation, operation, and also post-op follow-up. But, sorry. Okay. It is not about the operation, it is about the process. This what I mean. The process, the whole process for the treatment of the obesity is the most important thing. So for the pre-operation, the patient readiness is the key. If they have no intention, no willingness, and no knowledge, every operation is not the answer. You have to find the other way. So I think we have to talk with our patient, discuss with them about the goal of the treatment. And also consider the comorbidities, how severity of the comorbidities, and also the important things is pre-optimization by the multidisciplinary team. And also the initial BMI, the weight loss goal, the patient preference, and weight of benefit and risk, and discuss with the patient what is the best option for them. For the operation, we can maximize that by the surgeon. We have the proper patient selection, standardization for the procedure, good surgical technique, and minimize complication. And for the post-op follow-up, it is all the key. So the patient have to comply to the follow-up, strict to the diet and exercise, and also you should have a patient support group. So for the expected outcome and benefit. So what to consider, I will summarize as easy to understand that we consider the initial BMI, the weight loss goal for the patient, the comorbidities, the nutritional risk acceptance, and also the specific concern. For the initial BMI, I will classify as three categories. The first is over 32.5 to 45. I would say sleep gastrectomy is also enough from the data. And for the higher BMI, over 45 to 60, you should add the bypass proportion to the procedure for the best outcome, like a sleep plus, long wide gastric bypass, and the SAD. And for the extreme BMI, such as over 60, we have to use the bypass procedure also. But we can also do the stage surgery, like a sleep gastrectomy at the first stage, and then add on the bypass later. It depends on the patient condition. And for the weight loss goal of the patient, if your patient don't want to maximize the weight loss, we can use only sleep gastrectomy But for the maximum of the weight loss, I would say that sleep gastrectomy plus long-wide gastric bypass and SETI is the option. From the study, sleep pass and my clinical trial, that is, I think the largest RCT nowadays, with 240 patients who undergoing long-wide gastric bypass and sleep gastrectomy for about 5 to 10 years. The primary endpoint is excess weight loss. You will say that from the study, it is not significant difference from the statistic. But in the number, the sleep gastrectomy has a lower weight loss than the long-wide gastric bypass. And this also published about 10-year outcome. There's no difference in the weight loss of long-wide gastric bypass and also sleep gastrectomy, but not in the subgroup of the higher BMI, like over 50. So this meta-analysis compare the sleep gastrectomy and long-wide gastric bypass in the super obesity and also super obese. We found that at 12 months, for super obesity and also super obesity, the favorable outcome is on the long-wide gastric bypass. But in the 2 years outcome, the promising outcome is just in the super obese patient, but not significant in the super obese patient. So, and this comparison from our center, this subgroup analysis of BMI over 50 in Chulalongkorn Hospital that just published this year. You see that in all of time point, the long-wide gastric bypass have the highest total weight loss than sleep gastrectomy in our center. That follow up 1 to 5 years. And the period BMI about 54 to the 48 in the sleep gastrectomy group and also in the long-wide gastric bypass group. For the comorbidities, it depends on the severity. If you don't have comorbidities and all the mind, I would say that sleep gastrectomy is also enough due to the data nowadays. But patients who have a severe comorbidity like poorly controlled type 2 diabetes, to add on the sleep gastrectomy plus or long-wide gastric bypass or SETI would be the better option. As Sanit said, the higher in weight loss, the remission and improvement in the comorbidity outcome is better in the higher weight loss. And this comparative analysis of bariatric surgery and intensive medical therapy for diabetes is a 5-year outcome. You will say that in 134 subjects, the sleep gastrectomy have 25% who did not have any medication, and in the gastric bypass is 45% who have none of the medication. And for the medical therapy, I also have the patient who need the medication. And the maximum weight loss is in about 1 to 2 years, and a little bit increase in the weight loss after the long term, about 10 to 15 weight loss. And they categorize in the higher BMI than 35 and also the lower BMI than 35. That you will see that it is a difference in outcome between procedure and also in compared to the medical treatment. And this is also comparing the 5-year diabetes outcome between the operation. That you see that in the long-wide gastric bypass is better in the total weight loss than sleep gastrectomy, and also show the slightly higher in type 2 diabetes remission rate than sleep gastrectomy. And also the relapse rate was lower in the long-wide gastric bypass than sleep gastrectomy. Now we also have a prediction for the type 2 diabetes remission after bariatric and metabolic surgery. We have ABC score from the PARC and early from in Asia. This study in Asia that we use the age, BMI, C-peptide level, and duration of diabetes as a parameter to calculate the prediction. You have a patient who have score 4 or higher, we tend to have a complete remission about 50% and higher, and also the partial remission about 67 to about 90%. The higher in the score, the higher chance of you to have the complete remission in the type 2 diabetes. when compared to the diadem score and also the individualized metabolic surgery score, suggests that this ABCD score is better for predicting type 2 diabetes, especially in Asia. For the nutritional risk acceptance, patients who can accept the fewer nutritional deficiency, sleep gastrectomy is option. And patients who can adhere to more nutritional supplement and accept more nutritional risk can do the sleep gastrectomy plus long gastric bypass and SEDI. And for the specific concern, patients who are bridging to transplant, sleep gastrectomy might be the option. And for the high risk for the gastric cancer and who need a surveillance for the remnant of the stomach, sleep gastrectomy plus and SEDI will be the option. And for the patient with a high risk of gallstone, sleep gastrectomy and long gastric bypass is easier to access to the biliary tract. To summarize, I will summarize in a table that you see that we also use the candidate BMI, the weight loss that we expected, and also the severity of metabolic disease, the resolution of type 2 diabetes, and also add on the portion of small bowel bypass, overall complications, the list of malnutrition, follow-up adherence, and also as a conversion procedure. So, in conclusion, I think why choosing the right weight loss surgery matter? Yes, because the success is determined not by the starting point or speed, but for the obesity management, even though you use bariatric surgery, medication, or endoscopic treatment, it needs persistent endurance and making steady and intentional progress over time. Thank you.
Thank you. Thank you for a very interesting talk, and it's open to the floor. Professor Travis?
Please.
Thanks. Would you ever offer MBS to a patient who had not been tried on a GLP-1 agonist?
Yes, we offer the MBS to the patient who have the indication, because we think that the GLP-1, yes, is an adjunct to the surgery, and for the long-term outcomes that we expected, we will offer the MBS before the GLP-1.
Gosh, that's interesting. The second, we've touched on medical tourism coming to Thailand in particular, and you emphasize the importance on pre-operative counseling and post-operative follow-up. But if somebody came from London with a BMI of 35 saying, can I have bariatric surgery? Presumably you would just operate on them, wouldn't you?
No. I think,
are you sure?
Yes, as I said, I think we have to discuss with the patient about first, why they come here, and about their goal.
It's cheaper.
Yes. I would say that it is cheaper in Thailand. But I think for the principle, we have to choose the right patient. I think we have to discuss the patient of the previous trial of their weight loss management, or after surgery, can they adherence to the follow-up after they going back to the country?
How do you mean adhere to the follow-up? There is no follow-up after they go back home. There is no follow-up. Don't try and present otherwise, other than the fact that any complications which might arise are picked up by the poor physicians and surgeons back home.
Don't worry.
I'm being provocative, and I don't mean to be harsh, but I mean, they are important considerations.
Yes, I agree with you.
So we learn a lot in the AI. We have a telemedicine.
Oh, I see. Okay, yeah. So you have organized television. I see. Okay,
we can
thank you.
organize the patients.
Any other questions? In fact, I'm quite curious with an increasing supply or advancement in pharmacotherapy for obesity. Do you envisage one day bariatric surgery for obesity will be like vagotomy and pyloroplasty for peptic ulcer disease?
You mean for the peptic ulcer disease?
one day it will become almost obsolete with an advance in the development of pharmacotherapy for obesity. So do you envisage one day there's no more bariatric surgery, except for the very, very extreme cases? Yes.
Now we can operate only about 0.7% of all the candidate for the bariatric surgery. So this is not the first time that we face this question, because after the rising of the GLP-1 agonist, yes. And I think in the future, the efficacy of the medication will comparable to the bariatric surgery. But as I say, we look for the long term. The patient have to think about the long term efficacy, and many patients have problem with to use the medication for the long term. And I think we are a good friend to each other as a complement for bariatric surgery and the GLP-1 agonist.
I guess we are getting more and more philosophical. We are running out of time, but we have to thank both speakers. They have really done a marvelous job. Fantastic. Thank you so much.
Thank you.